drugs and defibrill. It's under
Miscellaneous.
ALS prep drugs and the miscellaneous. So basically, this is going to be starting for our getting a review into ACLS. So ACLS is going to be based on AHA areas, and it is a class from that. You guys will have to renew every so often, but I'm going to go a little above and beyond because I expect more from you guys as well. So when we're doing this and we're in the ageneric receptors, you guys should have this area down. So alpha-1 receptors, what does it cause? Alpha-2 receptors, beta-1 receptors, beta-2 receptors. Again, if I'm telling you, what these principles as we talk in the meds of what they act on to, again, my simple brain basically looks as alpha is 1, betas are 2. Alpha is going to be mostly my arteries, where betas is going to be beta-1, there's 1 heart, beta-2, there's 2 lungs. Those are some simple things I do. You guys find out which works for you. But I want you guys do have an idea of at least what these act on and what they are. We've done this and reviewed these before. In first module, you are going to be seeing these again throughout and knowing which medications do affect those areas. Dopamine is one of those areas that in a certain concentration, it gives you alpha properties, especially our lower concentrations, 2 to 10. Whereas if you go more 10 to 20, it starts giving you beta properties. So there are different aspects you need to know that about how you're giving dosages. So I do want you to know a simple aspect of alpha-1 receptors really are vasoconstriction. Alpha-2, sympatholytic, basically opposite. So it's going to cause vasodilatation. Exactly. Opposites on there. Beta-1 receptor, again, that's where our dopamine, leave them dead, and epinephrine are all going to. Aspect we're going to be going up to. Another important part from the test you guys need to know is what are those effects on there? Contractility, excitability, heart rate, chromotropic, dromotropic, ionotropic, bless you. Beta-2 receptors, again, knowing what we're going to be acting on. Again, there we're getting some vasodilation peripherally, depending on the concentration, but more importantly, we're getting the bronchodilation. So those are the things I really want you to know on those aspects. When we're dealing with ionotropic drugs, sorry, my tongue is going to stick here. What are we dealing with? Okay, what does ionotropic mean?
Strength of contraction and
Contractility. Yep. So again, ionotropic, dromotropic, chronotropic. Chronotropic is what? Rate. So it's rate. Chrono is time, so it's heart rate that we're dealing with. Dromotropic is what? Right. So how well is that heart muscle is going to be able to conduct and transfer? And ionotropic is the actual contractility, correct? Okay. So these are different drugs that are going to do that. Your beta blockers and diltiazem. What is diltiazem? Calcium channel blockers. So we talked about that heart rate, the beat or the action potential coming through the heart. Beta blockers and diltiazem are going to try and stop that, reduce those things. Calcium channel blockers and beta blockers will do that. What we want to do is we want to increase that. So what drugs do we have access to that'll increase it? Well, we got epi, dopamine, and then there is dobutamine out there. So those are different drugs that are going to cause those areas. So when we want to increase that contractility of the heart, we're either going to do an epi drip, epi pressor, push pressors, or dopamine. So because you asked, I'll give you this one on here too. So dopamine, what is the, how do I figure out a drip rate for dopamine? I've got a 176 pound patient. How do I figure it out? So anyways, I'm going to give you my 2 a.m. math because I'm not very smart, really. So basically what you do, real simple, this is the only 2 a.m. math I'm going to give you since you asked here. But let me give it for this. So for dopamine, what you'll do is give me a weight in pounds on anybody. I'm going to stop. 195. Thank you. I should say I was going to get 5 letters on there. So I'm going to do 195. I'm going to do 176. Now these are in pounds, not kilograms. Now this is based on our pre-filled concentration at 5 mics per kilogram, 5 mics per kilogram per minute, and based on the concentration of 1,600 mics in there. Basically, what you'll do is you will take this patient up here, and whatever the number is on last, you're only going to take the first 2 digits. So 5, above 5 we go up, below 5 we ran down. So this I make into 20, because 5 makes that up 20. Subtract 2, and it's 18 drops per minute.
And that's for the 5.
This is that 5 mics per kilogram per minute on dopamine. For this patient then, what would I do? I'd round up to 18, subtract 2, 16 drops per minute. So if you do the math, basically all this is a math formula. For a 176-pound patient, actually it comes to like 15.3. And this one here comes to like 17.6 if you went through the actual area. What's the difference between those two? Negligible. And how are you going to figure these out? Well, it's based on a 60 seconds. So 20 seconds, I'm going to go 1 every 3 seconds. I'm going to do a drop. So basically what I'll do is I'll figure in my mind is a series of weights that are going to be close. Anything that's around 15 is 1 drop every 4 seconds. Anything that's around 20 drops a minute is 1 drop every 3 seconds. That's how I figure out some of these quick math, but it's basically it's math formula. The only thing that changes in that formula, if you use 5, use the same concentration, what's the only thing that changes? The weight of the patient, right? This is basically using math to come up with that formula. I'll teach you more tricks, but if you ever have to do a dopamine drip, calculate the weight in pounds, get it down to the tens number, subtract 2, and that's your number. That's drops per minute. Question?
So that is for 5 mics per.
5 mics per kilogram per minute. So if I did the formula, that's our 1 over 1,600 micrograms times 5 mics per kilogram times whatever the weight is, X, over 1 over, or excuse me, 60 drops per mil. So
Would it be easier then? Say you're
no,
gonna give 10,
it wouldn't.
Say you're going to get 10 mics per K per minute, just to double those, or would you do something different with your
Yes.
CAM?
If you're going to give 10, you double it. Because 2 times this, so it's 2 times your number. If you were going to make it 2.5, it would be half that. But for our area protocols wise, we always start at 5. 5 is the area we're going to start because we're still getting alpha properties, basically alpha 1 properties, and a little bit of beta 1 properties to it. Once we start going above 10, we start getting to straight beta properties, and we start getting some other aspects too that we don't want.
Do you actually do that on some? Because I've seen dopamine once, and it's basically wide open and titrate to effect, and then scale down once we got what we want.
I've used dopamine once in my career, and I actually, yes, I do this, and I set it up at that rate on there. Because if you go wide open on there, you're getting the wrong effects because now you're going more than 5 mics per there, so I'm not getting the right effects. So yeah, I'll start it off, and I'll actually start it maybe at 2 drips, 2 drops per minute. You know, kind of getting set up there at 2 drops per going through seconds wise, and I'll start off slow, and then I'll titrate. But it gives me an area to start with. But yeah, I actually do that.
Well, wide open would essentially give you 15, right? Because after 15, it doesn't have much effect.
After 20, it doesn't.
After 20.
15 to 20.
But you can actually get more than that on there. So I'm not going to go too much in this because I'm going to teach you guys later about getting rid of dopamine and doing epi push pressure anyway. So I'm stopping. That was I've already gone off track.
Mine's about when you say epi push pressure.
Yes.
What's that word?
I will get to it later.
Okay.
Fair enough?
Yeah.
Okay. It does not apply to you at this point in time. I'll get to it when we get to it. Okay, chronotropic drugs. My tongue is stuck, sorry. Again, we're talking about what's going to affect heart rate. So again, beta blockers, digoxin, which is one of our drugs, calcium channel blockers, diltiazem, also a calcium channel blocker. are all going to be able to stopping those. What's going to help it? Our atropine is going to get our heart rate up. Think about bradycardic patients. What would we do? First option, we'll get into the heart blocks, but first thing I always want you guys to consider is atropine. Dopamine and epinephrine, not as a pushing drug, but as a drip, as a pressor. Dromotropic drugs, again, they're basically going to increase the contractility. The only two things there are going to be epinephrine and dopamine. Technically in this too is also going to be levofed, but I'm not really going to go over that and add that at this point in time. And obviously we know what's going to stop those. Pretty much have been the same ones out there. So why is this important? Because there's a lot of people out there on beta blockers, on calcium channel blockers, that have the ability to, one, double their dose and overdose on these, or two, have liver function, kidney function, other areas, and they're not getting it excreted completely, and so they're going into problems. So you need to know how do we identify what they took, and how do we correct that. So little heads up here, you guys are starting into the summative scenarios. Again, we're doing the easy level right now. Eventually, you guys, have you seen drug bottles popping up on scenes? Eventually, you might guys want to count those. There's going to be a date set on there. You might want to look at the date and say, does this number add up? Is there the right number in here to tell if they overdosed or not? So, hey, Dave. Morning. Come with me real quick. I'll meet you in the office. So, those are kind of things there. I just got a big one quick drop for Dave. But those are things you guys got to identify. So I want you guys to be thinking about that as counting. Is that the right medication? So those are all big things that I want you guys to be aware of and know what's out there. As far as our pre-arrest drugs, this is something that we check, and they've recently did the stroke one. They're doing the cardiac one today in Q&I meeting. Basically, what medications are we given when someone complains of chest pain? And one of those areas that you guys will find if you start doing reports is aspirin. Did you give aspirin? Okay. There's a couple reasons not to give aspirin, right? So you need to document, I gave aspirin for chest pain, or if I did not give aspirin, why did I not give it? Was it because they already took some recently within the time frame? Was it because they have allergy? Was it because suspected bleeding inside? Was it, you know, for whatever reason on there, this wasn't actually a chest pain that I realized is cardiac, it was more non-cardiac related. So I want you to be thinking about that, because anytime someone's complaining of chest pain and you look at them and you can kind of tell, are they having cardiac related chest pain, or if not, give them the aspirin. You know, there's reasons that we don't do, but find out again, are there any contraindications given it, and give it to there. Basically, it is not a blood thinner, but it does work on platelets. It does make it slippier. It makes the oxygen be able to slide past through things. That works that aspect. Oxygen, again, we're going to talk AHA. If they have a O2 sat of 94 or greater, don't give them oxygen. That's AHA. I disagree. My big thing is I don't want them more than 99%. And the difference comes into is once someone's at 100%, how much O2 are you putting into them? That's the part we don't know. Are we getting them? Are they at 110%? Are they at 105%? Or are they right at 100%? What we are finding out is if too much oxygen in the bloodstream, not binding, can cause oxidizing injuries, and it's creating what's called free radicals, and it's damaging the system. So if someone's having chest pain, I'm going to give them oxygen, probably give them through nasal cannula, but I'm not going to give them more than 99%. Once they're at 99, I'm going to dial it back down. So I'm never saying withhold it, but I'm going to pre-warn you for AHA question. If someone has a oxygen sat 94% or above, giving oxygen is not a correct answer for AHA. I disagree, but I just want you to be warned on that. And then pain management. That's the other aspect you're going to do. If someone's having 10 out of 10 chest pain, not relieved for nitro. Do we just let them suffer in pain? No, treat it. Treat the pain. We're going to talk about something. I have a different philosophy, so does Dr. Edminster. I'm going to see what Dr. Raby's philosophy is as we come in here. But nitroglycerin, basically, what does it do? Vasodilates. It basically takes the oxygen workload off the heart, but it drops your preload. So as we're going in and talking about those areas, our preload coming to the heart is that pressure coming up against the heart, and it's going to be filling back to the heart. If we drop that, that's going to basically decrease our blood flow in the heart and able to push. So we don't want to drop that, right? So what's the area of the heart? We probably have not got into this yet, but basically if someone has an inferior MI, ST elevation in the inferior leads in a 12 lead. I'll get to that, so don't freak. It has that. We always talk about don't give nitro because you're dropping the preload. I have a different philosophy on that. If you have an IV established and you're giving fluids, give nitro. The benefits of nitro of taking the workload off the heart are there, and you can compensate from the blood drop from that nitro with fluids. You're going to manage that. So that'd be a reason to give it. People talk about morphine and fentanyl. Which one can I not give for hypotension? Can I?
Hypotension?
Hypotension. Fentanyl. And most people do not carry morphine. District 4 carries morphine. AMR?
Nope.
So it's fentanyl. So if my patient is hypotensive from a heart rate, but they're in 10 out of 10 pain, not relieved, are you still going to let them suffer? No. I'll give them fentanyl. But I'm going to fill them with fluids and I'm going to help compensate for the potential hypotension. So if you know what's wrong, you can fix the area, you can go about that. Book answer, do I give fentanyl for someone with hypertension? No. Do I give someone with a nitro with an inferior MI? Do I give nitro to someone with an inferior MI? ST elevations? No. Book answer. I want you to know that. But real life, we are going to be pushing you guys to say, yes, you can do it if you can compensate to fix the issue. Yeah.
So I don't want to get off the weeds, but why is that not on an inferior MI when most people, if they've ever had angina, they're prescribed nitro, they're told to give them anytime you have chest pain? So.
Because most people who have angina, it's a different story, and we'll talk about angina down aspect. It's not an inferior MI. And if they all of a sudden develop it, it's, again, the benefits are still there. So what's funny is people can do a lot of things that we can't as providers. Look at what AHA tells us to do as CPR as providers. How do we teach CPR to EMTs? 30 to 2. How do we teach lay people CPR? Continuous compressions, which is correct. Continuous compressions. Can't give you a good answer.
Well, continuous compressions with oxygen.
They can't give oxygen.
Right.
So other drugs that are come out there, this is probably going to be our biggest drug you guys need to know and do. Epi is going to be basically on just about every algorithm that's out there except for fast rhythms. There's no proven side effect. I'll let you know, we actually used to do high dose epi a long time ago. Our algorithms was 1 milligram of epi. Next round was 3 milligrams of epi. Next round was 6 milligrams of epi. There's lots of different things that have been doing. It hasn't really been proven to effectively help. It hasn't been proven to be the aspect to get ROS, but it has a lot of good effects. So it's been utilized in multiple different fashions, but I want you guys to be aware of this because it has multiple different effects. And yes, I will get to you, talk to you later, more so when we get towards the pediatric aspect of the push pressors, but I'll bring it up a little bit when we do ACLS as well. It's just another way to treat this. But it basically helps the dromotropic, chromotropic, and ionotropic portions of the heart to give you the best effort to bring it back. Do you have a question or are you just thinking?
Question. Well, how does it affect the dromotropic, the electrical conductivity in the heart? Wouldn't that be something more of a big drug?
More of a what?
I don't know. I just don't understand how epinephrine would help the electrical conductivity in the heart.
I don't know the science behind it. I know it works. I will find out and see from that aspect. I know dopamine, epinephrine, and norepi all help with the conductile portions.
Okay.
And increase on that. That's about the best I can tell you.
I could say, remember we talked about getting catheter or bradycardia, so that we're reducing the amount of parasympathetic stimulation.
Right.
So that the sympathetic, giving epi, we're pushing more sympathetic stimulation on those receptor sites. So you're increasing the excitability of those cardiac cells. So you're actually increasing the rate and excitability.
Okay.
That kind of makes sense. It's like atropine takes away the parasympathetic, and epi gives you more sympathetic.
Which has all aspects of it to the heart. The specific chemical reasons why it does that, I know it's a sympathetic drug. I can tell you why norepi does, more so than epinephrine does, but epinephrine works into the same aspect. You look confused.
Oh, nothing. Sorry, I read an article about neuropathy. It seems to have less, or from what I thought, it had a less chromatonic effect.
It has less than epi, but I know the reason why it works. I do not know the background of why epi works.
Sorry, I got
No, I'm just saying I know why the chemical properties of those. I don't know why epi does. I know it does work. Fair enough. And I'm not going to ask that on, Gary's not going to ask that on the test question, but he does need you to know that it does have the dromotropic, chronotropic, and ionotropic properties. I can look that up. Actually, we have a cardiologist coming in. That'd be a great question for them if they know. Actually, a pharmacologist would even be better too. But I don't know. Sorry, it has not piqued my interest to do that portion. But great question. Our cardiac dosing, basically epinephrine for an adult is 1 milligram, basically 1 ampule, and we're doing it every 3 to 5 minutes. So pretty much how I look at it is if you give it within a 2-minute cycle, you're going to take a 2-minute cycle off, and it's going to be in the following 2-minute cycle. So it's every other cycle would be a time frame as far as dosing. Different areas that we have it into, we're going to talk about PEA. PEA I have different philosophy on, but right now PEA is one that you'd give epi for. Asystole, we give epi for. VFib, we give epi for, and pulseless VTAC. So those are some of our main areas that we have them for, and we give it every other on there. I'll talk a little bit more when we get more to defibrillation about the timing of when to use it, but basically that's where you're going to be considered, is you're going to be going through multiple of those. The other thing I am going to talk to you about in ACLS is making 1 to 1,000 into 1 to 10,000 epi, because we have had times, and we will maybe continue to have times of having drug shortages where we have the pre-filled containers and they're gone, and you've got to make 1 to 1,000 into 1 to 10,000. So I'm going to go over those with you guys too, so you guys are up on that. Vasopressin actually used to be in our algorithm for AHA for replacing epinephrine. The thought behind it is to replace your first or your second dose of epi, and it lasted longer and went over a bigger effect. Did more of a sustained release because it has a longer half-life and stayed in the system. Vasopressin is still out there. There's some departments and hospitals that still use it. Most people have taken it off their crash cart, because if they do use it, they forget that it's in there. They stop using epi. Some people used to give this and just stop giving epi at all in general. And it actually ended up causing more problems, and AHA is all about simple. They're too simplified in some aspects, but basically that's all I really want you to know about vasopressin. When this lecture was put together, we actually did have it as part of AHA. Now it's taken off. And pretty much it used the same spot that epi was used in. It just replaced the first or second dosage. And 40 ml equivalent was usually the dose given. Amiodarone is our go-to medication per AHA. Lidocaine is out there too. Those are equivalent as far as choices. AHA now says amiodarone or lidocaine. Amiodarone is the drug of choice because of math. It's simple, right? Lidocaine, you have to do math. 1 to 1.5 milligrams per kilogram. You have to think about it. Amiodarone, what's the dose? 300 and 150, depending on how it does. So it's dosed 2 different ways. So let's talk about this a little bit. When we're talking about cardiac arrest, so our patient is dead. We have what's called a dead dose. The way I look at it is dead dose is go big or go home, right? Throw all out of it or do nothing. So we do 300 milligrams, and we push it IV push. That's going big. After that, then we give the 150 milligrams. Again, IV push about 3 to 5 minutes past that. So if I've got a cardiac arrest algorithm, and I've given you guys some of the sheets, my algorithm, if I see VFib, is I'm going to defibrillate it. As soon as I see it. Witnessed, unwitnessed, I want to take that out of your vocabulary. VFib. See VFib on the monitor, you defibrillate it as quickly as possible. They're going to do 2 minutes of CPR. In that 2 minutes of CPR, you guys are going to get an IV established. You guys are going to get your airway worked on, whatever you've got on there. And you're going to get everything monitored with the monitor and everything all set up there, so you're all set to go. That's it. Now you're going to wait until those 2 minutes are up. If that patient is still in VFib, what we call refractory to. When we say refractory, it just basically means we did something, and despite doing it, it maintained. So if someone's in refractory VFib, it means we shocked them, and they stayed in VFib. So after the first shock, if they're still in VFib at our next rhythm, we're going to shock them again at 2 minutes, and now we're going to do epinephrine. We'll start our protocols. We'll do epinephrine 1 milligram. After the end of 2 minutes, we'll shock them again if they're still in there. In that next 2 minute cycles, we'll start our 300 milligrams of amiodarone. We'll shock them again at 2 minutes if they're still refractory. Next 2 minutes, we do 1 milligram of epi, shock them again. Next 2 minutes, we do 150 of amio. That's kind of the philosophy where I want to get you going. That's basically with our protocols. Fair enough? Our live dose is the second dose. So live, my statement is go low, live, go low and slow. Dead, go big or go home. Live, go low and slow. So what's the low dose of amiodarone? 150. So it's 150 and we do it slow, so we do it over 10 minutes. There's a couple different ways to do that. Amiodarone is a drug that you actually have to dilute. It's supposed to be diluted. If you look at your vials, we usually carry it 3 mils, 150 milligrams in 1 vial. You're supposed to dilute that with 10 to 20 cc's of normal saline or D5. So easy way to do it, take a flush, shoot out 3 cc's, drop 3 cc's slowly. There's 10 cc amiodarone. You can push 1 cc a minute because you have 10 cc's, right? Every minute, push 1 cc. That's low and slow. Easier way, because we're starting to carry 100 milligram bags. Shoot the 3 milligrams into 100 milligrams, flow it over 10 minutes. Simple. But that's low and slow. So 150 slow over 10 minutes diluted, or in a cardiac arrest, go big, go home, 300 milligram IV push followed by 150 milligram IV push.
Quick question. What happens if someone just slammed it?
Or when they're alive,
Or
you could actually drop them into a bradycardic rate.
Okay.
Because you're basically stopping the heart ability. You're trying to slow it down. So if you give it too fast in a live dose, you can actually, again, it works on beta blockers, same as sites do, same as the potassium channels and blocks calcium. It'll just decrease your heart rate. Yeah. Yep. So basically, you got to think of it. If I give it for people who are going too fast, what's the medication going to do? It's going to slow them down. So if I give them too much, it's going to slow them down too much. Yep. And I'm not going to go into this too much, but basically, I'll let you know this is used in hospitals in a different setting, but I'm not going to go into those. I can talk to you guys outside stuff, but I don't want to muddy the waters.
Is it only diluted for live dose?
Correct. You can dilute it. They talk about diluting it technically for dead doses as well. For time frames, I have not yet to see anyone do it. So basically, to compensate for that is as soon as you push it, either follow it by a flush or squeeze the bag.
So what's the reasoning for the dilution need? Is it
It's basically so it hits the heart in a sustained area and help get that up because it's so condensed and concentrated. It helps to space that area out and flow evenly to the heart so it strips.
A lot of medicine coming in.
Correct. And that's why we shoot a 20 cc flush after it. 2, 1 to clear the line, 2 basically to help dilute it from that aspect. And 3 also, especially in cardiac arrest, we need to give it that extra push so it gets to the heart because the only way we're getting that heart moving right now is us pumping on it in cardiac arrest situations. Lidocaine, basically lidocaine is that other medication that we can use. It actually was our primary drug before amiodarone was put into it. I'm not going to really go over the dosages, but basically it's similar to amiodarone where your primary dose is 1 to 1.5 milligrams per kilogram. Your secondary dose is 0.5 milligram to 1 milligram per kilogram. It can also be used as a drip in a sense for people when they're in a BTAC in a live situation. It works fantastic for that as well. But again, it's the dosing problems on there and it's the math issue. Yeah.
If they're over 70 and dead, you still have it. It's not just the live dose.
The dead dose, you have it.
Okay, so if that was something, so
Yeah. According there, but instead of halving it, instead of 1.5, you just give it 1.
Okay.
And it's pretty consistent, 1 milligram per kilogram straight across over 7. But again, that was old school changes, and people are coming through. It really comes on the patients and how they're doing too, and how they're polypharmacy. There's so many variables right now, which is hard on there, but that's where I would give it for that aspect. But yes, for over 70 live dose, you do have the dosage. Again, fantastic medication. The problem with this is the math that's associated with it. You start adding math into the equation, it makes things more difficult. People have to think about it, and so they like to use other medications. So lidocaine is not as popular as amiodarone for that specific reason. I still think it's a fantastic drug. It's got a shorter half-life, has got a lot of properties to it, and if you've done it in the right hands, it's a fantastic medication. I still think that. Here's the 2 ways we just kind of talked about. As a rapid dose being pushed into this, you do not need to dilute lidocaine. It's just pushed in rapidly, or you can do it as an infusion. When you think amiodarone, think lidocaine. They're synonymous, same treatments.
So they slow the heart down. If you give it a defib, does it kind of slow that quivering down to give you more chance to?
It's designed to increase the absolute refractory period to keep the heart from resetting. Remember, relative refractory period, again, just highlighting some stuff in the test questions. I think you did a great explanation of that. It means that the heart is trying to repolarize, but given a strong enough impulse, it can rebeat again. Absolute refractory period, no matter how strong the impulse is, it will not beat again. So yes, you're trying to basically reset the heart. So when we talk about our live patients that were coming in that are going a fast rate, we're trying to stop the refractory period, make it longer so that that heart has to get reset. And so we give medication for that. And the reason we give medication is we have time to give it, right? They're a stable patient. We have time, so we're going to try and give medication for that patient. We're going to increase that refractory period. Hopefully the heart resets on a normal cycle and slows itself back down. If they are unstable and they're moving fast, one of the things we're going to talk about is cardioversion, meaning we're going to use electricity at a specific point in time to knock out the refractory period of the heart to try and reset itself. So we'll talk about those. What I'm doing today is mostly just going over drugs, and most of our drugs are in stable scenario situation. We always have 2 ways to treat all our algorithms that I'll talk about. We have electricity and we have medications. Which works faster? Electricity. So if I have an unstable patient, my first treatment is always going to be electricity. And electricity, the formats I have is defibrillation. We talk about shock, but defibrillation specifically, cardioversion, and transcutaneous pacing. Those are our 3 versions of electricity we'll use in our ACLS protocols. But if our patient's more stable and we got a little time to play with them, we'll try our medications first.
Is that just patient comfort? Is that the reason?
No, it's basically, well, in a sense, yes. I mean, I can take a stable patient and I can cardiovert them, but yeah, it's going to hurt. But we'll talk about different things you can do. But I've in certain situations where I do not have time to pre-sedate my patient and I shock him and then it's going to hurt. It's the only thing saving their life. So.
Electricity is finite for
Over a period of time. Yeah. It's how quickly I need it to work and everything else too. A lot of different things come into play. So atropine is basically going to be used in what algorithm? Bradycardia. Symptomatic. So because some people, I've had people come in that have a heart rate of 50 and that's their normal operating pace. That's not symptomatic. So symptomatic bradycardia. So basically atropine is going to be given in 0.5 milligram to 1 milligram. Our dosages normally is 1/2 milligram. So 0.5 milligrams we give. It's given over 3 to 5 minutes, same as Epi does, and it does a max dose of 3 milligrams per kilogram. So we can use it multiple times. My thought process is on this, if I've used it twice and it's not working, I'm probably not going to keep giving it up to 3 milligrams. But if I'm seeing some progressive change with it, I'm probably going to keep giving it. Otherwise, I'm going to move on to one of my other options, which most likely be pacing. This works most of the time. You guys got into heart blocks a little bit, right? So atropine will work in a heart block situation, normally in a first degree type heart block. Sometimes in a second degree type 1, but high degree heart blocks, which is second degree type 2 and third degree heart blocks, atropine does not work. So for AHA, as we're getting into the protocols, basically the thing to say is if you see someone in a second degree type 2 or third degree heart block, is I would consider atropine, but given that this patient is in a high degree heart block, I'm probably going to go straight to pacing, or I'll go on to a pressor trip.
So would you give atropine just because it might work, and if it does,
If I put them on a monitor and I don't have a line established, I'm going right to the pads. But if I have a line established and I'm setting up my pacing, yeah, I might give it to them. But I have to say that per a lot of these protocols. In my opinion, if I see the third degree heart block, which I had one the other day, I didn't even touch atropine. I just went straight to pads and just paced them. And instead of taking my time to put together my atropine, I pulled up my Versed. So, absolutely. I've never done it. I go to pacing because I know it works. And I have not had pacing not work for me, so I don't have a good reason for it, but I know it's one of our choices, so obviously it must work well. But me personally, I've never used it, so I can't give you any personal reference, and I don't know anyone who does. You had a question?
I guess the book mentioned, I believe, organophosphate poisoning, and you can exceed that 3 milligram dose.
Correct. That's the only dose. Atropine has 2 indications. 1 is bradycardia, 2 is organophosphate, and that's 2 to 6 milligrams.
Max.
No, that's the dose. Per dose.
Oh,
Yeah.
okay.
Now you can go 12 milligrams atropine for organophosphate poisoning. Different aspect.
Have you run across?
I have not come across organophosphate, but it could be very common around the area with all the things we have, but I have not. Magnesium.
You mentioned Versed, was that for the pain for pacing?
Yeah, that's for sedation. Yeah, sorry. Thank you. Good question. Yeah, pacing does hurt, although I'll let you know. So again, and it goes back to this aspect, this is not being racist at all. Russian women, Native American women have got some of the highest thresholds of pain I've ever seen. I paced a 50-year-old, okay, I got to step back in. Ukrainian, Russian, all areas. I do not want to be discriminative of that area. She was of that part of the world. She sat, could be Slavics on there. I don't know exactly where she's at, but I knew she spoke Russian, but that the dialect was there. She sat and looked at me as I paced her at 100 milliamps. And she looked at me as her chest is just doing that. And she's just staring at me. And I'm like, do you need anything for pain? And just nothing. You just ask her there. The one part of Russian I know is Очень хорошо. Very good. Очень хорошо. She points at me. Her chest is just going. I did it on a guy, white male. He's screaming in bloody pain. Worst pain at all.
Mid-20s, probably.
No, he was 40s. But screaming in pain. So, and Native American women.
And some of us old guys have problems.
Yeah, Native American women, again, what it is, just stoic. But it can be men too, but I've seen those two women be more stoic than any other patient I've had. They just can have a high threshold of pain. Magnesium. So where we're going to see it mostly when we're talking about ACLS and the algorithms is going to be in torsades. Torsades, just so you know too, is the only rhythm that you can defibrillate with a pulse. You see this, and they actually have a pulse, you defibrillate. This is a serious rhythm, and this is non-functional. They will not stay with a pulse very long if they have it, but this is the only rhythm you can defibrillate with a pulse. We can cardiovert, not shock, defibrillate. So that means, and usually on these, I start with 360 joules if I see this. So magnesium in the ACLS world, 1 to 2 grams on there. Again, I'm in a rest situation and I've seen this, and I've only seen this twice. Yeah, twice again, I give 2 grams. 1 to 2 grams is a range, yeah.
So not to contradict you there, but I think Dr. Rady was saying yesterday, kind of don't shock torsades, because it's not going to fix that, because it's a bag. But so would you say that that's still the first line? Like I'm going to shock them, see if I can get them out of it for a minute. And I'm still going to give a mag if I stop torsades.
The purpose of that is If I pop this up online and I see this while they're going through, I may not have an IV line in place. I'm going to go to shock this because they're going to go to that aspect, and I can shock them out of that rhythm potentially quicker than I may get a line in place. I will agree, I will agree from the standpoint, defibrillation is not going to be my first line of treatment. If I have an IV line and something else to give them, I'll give them medication from that because they still have a pulse, so they're in that area. But this is the only rhythm that I can defibrillate. Maybe I'll change my terminology. Fair enough?
Yeah. Okay. Do you get people with torsades and like wait and talking to you?
I never have.
All right.
Oh,
It's the unicorn, and the 2 times I saw it, it was on the screen momentarily, and it was gone. So, just a second, Jeff.
So you were saying that the cardiac dose is 2 grams. So in our book it was 1 to 4 grams. When did you get 4?
Eclampsia.
Oh, okay, fair enough.
Eclampsia is 3 to 4.
Okay.
Heart torsades is usually like 1 to 2 range. I'm also going to give like 1 milligram probably for asthma, for smooth muscle relaxing. I'm going to do an infusion drip for traumatic brain injury. For commotio coriacis or commotio contusius, I'm going to use probably 2 grams. So I have different functions of why I'm going to be giving this. So a question was brought up before. Is anyone familiar with commotio cordis or commotio contusion? So basically what, did I get to your question?
they didn't answer it.
Okay, I apologize, sorry.
No, you're fine.
Commotio cordis and commotio contusius is basically when you get a force to the heart. Commotio cordis is basically, think about the 12-year-old kid who got a line drive hit at him, the softball, hardball, baseball hit him right in the chest and they drop. The other aspect, and I've got videos of these and I'll talk to you about these later, is the karate contest, martial arts, where one kid basically pops him in the chest immediately and the kid just sits there and he falls to the ground dead. So basically you caused a stretching to the heart. Commotio contusius is a contusion to the chest and cause the heart. Basically, my philosophy behind this and what it is you get actual stretching of the heart muscle. That opens up, you release potassium out of the heart muscle, you release sodium up there, you open up all the channels because now the channels aren't effective because you've stretched those muscles and that heart immediately goes into a V-fit normally. It's also what's called R-on-T phenomenon. Sometimes you'll see when you get a contusion pressure of the heart, it opens up. It'll go immediately into fib. Sometimes it doesn't. The reason, though, on commotio coriacis and contusius that I'm worried about is you actually get a stretching of the heart muscle. So you release a ton of potassium out into the system. So you got to treat for that as well. And the treatment for hyper K, that's actually sodium bicarb.
It is.
Yep. Calcium for calcium channel overdoses. But for cardioprotective, you use magnesium in those cases, relaxant on there, and then as well as sodium bicarb. But anyway, so magnesium in this case is torsades. You see torsades, be thinking 1 to 2 grams of magnesium.
So you said you saw it once or twice, just real quick. Did you still push mag?
Absolutely. I pushed mag. Actually, one of the conditions I saw was a, quote, traumatic arrest. It was a car accident, airbag deployed into the chest, and we saw torsades on it. So we defibrillated because he was a pulseless. We gave 2 grams of mag and we gave sodium bicarb immediately because of the situation of the compression of the heart and the stretch. Where normally I wouldn't give sodium bicarb until about 10 minutes from the time of arrest. And the second time I saw it, it wasn't traumatic. We just saw it and we gave it.
So it's not something that really comes as a rhythm. It just kind of comes through, it's gone, perhaps.
Yeah, well, and most of the time you're going to see it in cardiac arrest. So you're going to see it for that 5 to 10 seconds while you're doing a pulse check. And then as soon as you stop, it's gone on the next rhythm. So you didn't capture it in that time frame. Otherwise, you're doing CPR on them, so you're not going to see it. Dopamine, again, it's another pressor that we can use. It's usually done as a drip, and it can be piggyback infusion. We talk about, too, when we're giving dopamine, we usually do it as a piggyback line, and that's why Gary wanted you guys to do all the piggyback drills and that. It's usually not done as its own line. They like to pop it in as on another line that's already there, and then you'll take it off and eventually flush it. It can be used, obviously, after we get ROSC is going to be the most commonly time when they are hypotensive, but not hypovolemic. It's going to be main indication. But this is also used in for bradycardic rhythms for its properties to help get the heart rate up.
So he talked about that 5 to 15 microkilogram range. Is like 10. Where's the area where it affects both the alpha 1 and beta 1 receptors?
It's in the 10 to 12 range. It's kind of in that midpoint. That's where I kind of talk about the 2 to 10, 10 to 20. 10 being kind of my mid-break part.
So in an arrest situation, you bring back the Ross and start at 10.
I usually still start at about 5 and build back up from there because depends on where am I looking for aspects to it too. Because I've got usually when I get Ross, I've at some point in time already given epi and given another spot, so the heart's already got that aspect on there. It's normally the vasoconstriction that I'm looking for, the peripheral aspect that I'm looking for, which is my alpha 1 properties. So I'm usually looking for it for alpha 1 properties, not for beta 1 properties. But if I'm looking for beta effects, then I would go higher on that aspect. Usually I'm not looking for beta effects because a lot of my Ross, and I don't know what you guys see, they're coming out at a heart rate of 100, 120 because of all the epi that's been on board or other aspects. So they're already up on the rate. So I'm not worried about the rate contractility. I'm worried about more of getting that preload back up.
You see braiding down and go straight, open up the dopamine a little bit more.
You can.
I've had several Ross where you get back 100, 120, and you start braiding down slowly.
If you've got a dopamine drip going, if I pop it up and see if you can get them up on that aspect. Some people will go to epi, and I've seen some people give, again, if you go outside of protocols, but you know why? I've seen people give a 0.5 milligram of epi for that, and I've seen people give a full milligram of atropine. Just depends on what you're doing and your experiences in that too. But if you've already got it in play, you've already got there, how easy is it to do this versus it is to go put together a new ampule and find out something? So, fast rhythms, supraventricular tachycardic. These are rhythms basically over 180. A lot of cases they're usually over 200 range as well. This is basically the atria beating completely. What we want to do, we call it supraventricular because this is up above the AV node where the rate's coming from. And so we want to slow it down. Adenosine basically works to stop that conduction of the AV node. And so it slows that conduction process getting down to it. Dosages on this is 6 milligrams for the first dose. It's a rapid IV push. So if you have an IV line with 2 ports, you want to be the closest to the heart, followed by a 20 cc flush to make sure you're pushing it to the heart because it has such a short half-life. So you want to get it to there as quickly as possible. That's what the push is behind it. There's new thoughts and changes because a lot of times we'll see out there, and I don't know if you guys have seen this, but a lot of times the first 6 milligrams does not work. Then we go to 12 milligrams. Then technically there's a second 12 per our protocols. It's usually called medical control, but it's 6, 12, 12. There's new studies going into place of just going 12, 12, starting out at 12, because the thought process is 6 is not working because it's not enough of it's getting to the heart. When you do 12, now there's enough that got there. So there is going to be some thought processes that change. But until then, 6, 12, followed by another 12 if you call medical control. Got it? Okay. So this does go to a question that Trevor asked me last night, though. So I'm going to briefly touch on that. Wolf Parkinson's White. WPW. We do not give it because there's an alternate pathway, right? So area that I wanted to talk about on this, and this is my poor drawing here, of course. So we have our SA node, our AV node, bundle of His is right here, and then we have our right and left bundle branches into our Purkinje fibers, okay? What there is there's an alternate pathway with WPW where this conducts into here, and it can start a conduction into the ventricle. Again, crude drawing, do not take this as scientific data, please. Just for explanation, it's like my detour. Doesn't real life go around the block. This is just my dumbing it down, okay? So our pulse comes, impulse comes here, our action potential comes down through the atrium. I know this isn't the right atrium, I go like that, but comes into the AV node and starts our process down. The conduction speed through here, and I'm throwing out numbers for explanation. Do not take these at face value, okay? So our conduction speed through here, let's say is 30 miles an hour. Our conduction speed down here is 100 miles an hour because we want to get the conduction from here down to here because we want this contraction to go up this way, right? We want this contraction to come down into the ventricles. We want the ventricles to come up here. So we want the conduction to come down here so that now it excites and contracts this way up to pump the blood up. So it speeds down here, and then once it gets up in here, this conduction is about 2 miles per hour when it comes off the Purkinje fibers, because it's coming up here. This conduction speed, about 2 miles per hour. So that conduction that comes down the ventricle is really slow. It takes a while to get from here down to here. So with our normal pace when we're beating, the ventricles are already contracting by the time this comes down and starts this excitatory contraction at this point. So they're already going to the normal pace. It's going faster than it comes down here. When we use adenosine, we block this, right? We block that rate because we're trying to reset it. Well, when we block this rate, we've now stopped this, but this still keeps going. Now this gets here before this gets up here. So now this is the start of the contraction because it was going a little bit faster. Now the beat starts here and starts going this way. And that's what can throw, this becomes your primary contraction of the ventricles, not down here. So it'll start beating here. And if I just start this off right here, what happens? Well, we talked about the excitability and how all the muscles are just, it starts, that is the primary point. So the heart just starts beating in a random way. So that goes into B-fib. So that's why if you give adenosine to someone with this altered pathway, we're not stopping this pathway, we're stopping the conduction to the AV node. Absolutely. Get them into a stable spot. Put them in asystole. That's stable. I know how to treat stable. So this is dumbed down. This is not, take it for thought, but does that explain it? I'm trying to find an easy way to explain it. Someone can explain, a cardiologist could explain this much better in that term than I can.
Things like amyloid still work because that slows down the entire action potential, right? That'll increase all the tires.
Yes, but I don't want to go there.
Okay.
Actually, amio is used in the hospital, but I don't want you to be thinking about it. I want you to be thinking about adenosine. Okay. But yes. Yes, amio, actually amio is used for SVT in the hospitals for that specific purpose.
Your mom was so proud.
If we ran into somebody with WPW and they knew and they were experiencing that, could we call medical control and be like, could we try a?
Actually, and then they'll do, amio is not given as a push, it's given as a drip, and you have to put it to different areas. And it's given at 2.2 grams over a sustained 24-hour period. It's a different area. But yes, absolutely. So if you see that, then yes, if they're in that area, you need to talk to the,
So we call medical
exactly. And then they'll tell you exactly how to do it. And you have all the medications to do it in the correct way. Great question. So,
Just shock.
just always. Very good. Asystole is the easiest rhythm to work with. Just get everyone to asystole and then just go from there.
Initially.
Yeah, no, that's what I'm saying. Just get everyone to asystole. Someone's having difficulty breathing, get them into asystole. You know how to treat them.
Not Trevor should run a double medic for
Clarkston,
shock
stay down
everybody.
there.
So we, whoa, you got it, Clarkston.
I'm coming, baby.
Don't bring us any lower than we have.
Okay. So again, that's basically what I want you to know too is the 6, 12, and 12 for adenosine. Sodium bicarb, again, this is the only medication I've seen that actually has some proven effects because it basically takes over the metabolic acidotic properties that are going on from the heart being down. It works for multiple different things that we know, but where I want you to do is we have a 10-minute timer in the fire department that we talk about. I want you to put a 10-minute timer on the patient. Not from the time you get there, but from the downtime. So if you come on scene and this patient has been down for 8 minutes, you got 2 minutes and you should be given sodium bicarb. The correct dose is 1 milliequivalent per kilogram. We usually give an amp of bicarb. That's easy philosophy. It's usually less than they need. The reason being is basically our medications really work well in an acidotic environment. If you give them too much bicarb off the bat, you can actually make them alkalotic and the medications don't work as well. So that's the one area where I can say if you give an amp of bicarb, and you see that happens all the time on scene, we usually carry 2, sometimes we only carry 1. But if someone just gives them 1 amp of bicarb, I'm acceptable with that from the standpoint of keeping them where they're at. But if you're 20 minutes in, you better probably be giving 2 amp of bicarb because they're very acidotic metabolically at that point in time.
So you said in 2 minutes throw an bicarb within our protocols?
So 10 minutes from downtime.
Okay.
So what my scenario was, you show up on scene, they're 8 minutes been down. In 2 minutes, you should consider giving sodium bicarb. Does that make sense?
Regardless of
10 minutes from the downtime, I would be considering that. Sodium bicarb is actually not in any AHA protocols. It's actually not even one of the AHA drugs per se, but it is within our protocols to give, and that's kind of the area you should be in there. Does it have to be exact? No, but that's what you should be thinking is 10 minutes downtime. How alkalotic or acidic is the body? Very.
So unknown time down, maybe an hour. We can push you right out.
Then I'm going to place it based on, I'm probably going to, well, I got to get my time to get my IV. I'm probably going to check where my capnography acts. I might get a little history on that. But probably within the first 2 minutes of having those. Yeah, if they've been down for a long time, absolutely. It's
the last thing that's
why wait? And I have had more conversions and ROSCs from giving sodium bicarb than any other medication out there. It's the only one that's proven. So that's why I want to push, and I've been pushing to every class in here to do it and be thinking that 10 minutes because most people it's not in there. I was never taught this throughout going through. It's not a medication taught. It's not taught in AHA. That's why I'm teaching it. That's why I want to push it out there because it is effective. It does work, and there's science behind it.
The thing that bothers me, I've since learning about sodium bicarb a while back, I've asked every medic, like, how long do you wait till you give me something? They truly don't.
Yeah. So that's why I'm telling you guys. Here's where it's going. You're going to start seeing this, and hopefully on the next 2020 guidelines for HA, we'll start seeing sodium bicarb in with time frames on them. So.
When you've got an arrest or something like that, there's not the best perfusion going on. How long do we want to wait before we start pushing heavy systems as well? Since it, it's the chemical.
Well, you're pushing your heart rate, right? So you've got circulation going. You're going straight to the heart is where you will go into it. You're not going for it that aspect. You're going for it to basically excitability in the heart and get things going on there. So you're pushing it right away for our protocol. That makes sense? So after 2 shocks in VFib, PEA, you should be doing it as soon as you get an IV.
So on the bicarb, one thing I had read was that when it's initially given, you see a huge spike in CO2, and without a definitive airway, you're not getting rid of that CO2. So it was talking about wanting a definitive airway before the bicarb.
Usually, but you should have a definitive airway.
Yeah, it should have taken 2 minutes.
A definitive airway is an IGEL, King airway, definitive airway. So if you're on scene,
yeah, hopefully BLS has got a
yeah, then you already King. All you're doing is you're putting your capnography on. So you should have an area on there. So don't forget, again, so we're going to talk about our H's and T's. One of the H's that has been removed is hypoglycemia, but don't forget hypoglycemia. It's going to be a very important aspect in there. So be taking their blood sugar. Again, we talked about taking blood sugars off the venous.
Why did they remove it? Because that's one thing we always do is
I don't know.
check the sugar of someone down in a cardiac arrest.
I don't know. Don't know what's why in there. It's basically, it's simplicity. There used to be 6 H's and 6 T's. Then there was 6 H's and 5 T's. Now they made it into 5 H's and 5 T's. Again, I'm going to teach you guys the correct way. Here's my philosophy, and if you ask any of my past students I've taught, what do I always tell them? Just do it right. No, I don't say that. I just say just do it right. You just do it right the first time, you don't have to worry about it, right?
H's and T's are established AHA terminology.
It's AHA terminology, but yeah, but it works out there. We all use it from that aspect. But I have different H's, and I'm going to talk to you guys about the H's you guys can control and the H's you guys can't control.
There's no scientific background as to why they took the. Okay.
There may be. I don't know what it is. Not a part of the medical part, so can't give you that answer. So, but be thinking about that. PEA is going to be the biggest reason for checking your H's and T's. It's important in every single algorithm, but PEA is the most important one, and I'll go over that further down the road. And Narcan on here, I have a different philosophy on Narcan. So Narcan, are they overdosed? You know, and we think that's what's gonna get them out. We're not intubating them, we're just gonna get from there and take it out. But if my patient is down and I've got them intubated, do I really want to give them Narcan? what's going to happen if I give them Narcan? I'm going to wake them up. And then what am I going to do? I'm going to re-put them back down because I'm not going to extubate them once I got a tube in place. So there's thought process behind that. If I know it's an opioid overdose and I chose to tube them, that patient's going in like that. I'll let the hospital deal with them.
Will you give them a little bit?
But that's why I'll either give, if I'm going to give them Narcan, if I'm going to consider, and I think this is an opioid arrest, I'm going to give them Narcan and I'm not going to tube them. I'm not going to just pull it from the tube. If they're in a full arrest from that aspect, I'm not worried about that because I know that's what it is. I'm going to stabilize them back, or I'll just give them, like I said, 0.4 on their small dosages. But I don't want them to be jumping back from that standpoint. So there's different philosophies on that, but I want you to be aware of Narcan out there. Talk to Dave Heiser, his opinion on it. He'll give you that. Right, but it's true. As far as defibrillators, this is going to be a skill we're going to be going over in lab tomorrow. So there's multiple different kinds out there. Just be familiar with yours. I'm going to have you guys be familiar with the LifePak 12s for in here because that's what's going to be yours for now. But be familiar what yours are. That's a Zoll. This is a Phillips. So there's lots of ones out there. There's actually, I've been into clinics that still have. I've been to clinics that still have paddles. So paddles are still out there. That one has paddles. So just be aware of those different aspects that we're going to be going over. Defibrillating, again, know what you're dealing with. Some have different protocols of going 2 escalating joule dosages, 200, 300, 360. Some start straight at 360. Some are biphasic, and they're at 200 every time. Cardioversion, we're using less dosage, and we're doing it at timed events. Bless you. So we want to stop the heart at a specific event. So it's a timed event that we want to go to. So that's why it's synchronized, and so you'll see a pace strip at the R wave because we're actually going to knock out the area. So it's a specific time event. We usually start with lower amount of joules, and we increase them up with stacked shocks. Stacked shocks means we shock. Did it work? No. We shock. Did it work? No. Did we shock? Work. Whereas defibrillation, we shock once, and then we hold off 2 minutes before we go again. Do you have a question? Oh, yeah. I thought your hand kind of went like that. So, no.
Well, 360 joules would be very well. It's 200.
You mean if you were touching? I don't know that I've been hit by a joule, and I can't remember what it was. It was in my, back in '92. I don't remember what the joule was, but I felt it, but it wasn't that bad.
I got hit about 5 months ago, 200, but I had a patient jump, and I what the hell?
Yeah.
And then it looked up.
Hard to say the conductivity. I don't.
The charge and the shock button.
Yeah.
The belt charge shocks up right next to each other.
Yeah. But we have ours down lower. We push the wheel. So I don't know about that. And then cardiac pacing. So we're going to go over all these skills. That's basically using the same pads on, and we're just using different weight to basically pace that heart and get it beaten. If you have actual paddles, then yes, you have to be sustained and touching while you're doing it. So different devices that are out there. The auto pulse, that's the Lucas we talked about, and then the rescue pod. The rescue pod is basically a thought process that you put it on top of the ET tube and then you bag through that. It's supposed to put like a little bit negative pressure to help maintain the lungs from that aspect. And it's got this neat little button right here, which you click it. It's like that games, if you ever been to Chuck E. Cheese's or that, and the light goes around and you try and stop it right at the immediate time. It's like that. This light goes around, and how often do you think it goes around?
Every 6 seconds.
Every 6 seconds, because you bag every 6 seconds. You guys have that at Sacred Heart, don't you? Yeah. So Sacred Heart's the only place I know. The Holy Family's not using it, but Sacred Heart's the only place I know it's used. So different things that are out there just to be aware of. The Lucas?
Backboard one, yeah.
The backboard, the auto pulse?
I've never seen that one actually run.
I have not.
Talking about that we got rid of.
Oh, that's the one. Okay.
They're terrible.
Yeah.
It was a big old garbage battery.
I got the backboard,
And it's so hard to get under.
get the whole station moved out of the way, but you guys back from the